Well, good morning, folks. I'm Michael McGinnis from the National Academy of Medicine, and it's my very distinct pleasure and privilege to welcome you to this meeting on improving care for high-need patients. This is the first of 3 meetings that will be held over the next year or so on the issue, and the meeting series is sponsored by the Peterson Center on Healthcare for which we are very grateful. The Peterson Center for Healthcare, you'll hear from in just a minute, is an important new ally on the healthcare scene. And I think testament to their importance is the forging of a partnership in the conduct of the series and this program that I'd like to refer to in just a minute. In fact, what I'd like to do at the outset is underscore a few things about the significance of this particular meeting. This is the very first meeting hosted by the National Academy of Medicine. 6 days ago, the National Academy of Medicine was launched as one of the 3 national academies which reside in this building and the building up the road on Constitution Avenue, and which are charged with providing counsel to the nation on matters of science, engineering, and health policy. I won't go into all the internecine dimensions of what the creation of a National Academy of Medicine means, but the short of it is that it's an important step for health and medicine throughout the nation. And no meeting, from my perspective, could be more important as an inaugural meeting than this one for a variety of issues. First of all, it's obviously about improving medical care. Improving medical care for our most complex conditions, and improving medical care for those populations who are most in need. Fundamentally important mandates to us as an academy, and with the blended dimension of advancing the frontiers of knowledge. Because as we look at these issues, it's clear that we not only need to focus on the biological issues involved and the medical therapies involved, but the interfaces of those clinical interventions with the dynamics in society that shape people's futures. The other dimension of this particular meeting that makes it so fitting as an inaugural meeting for the National Academy of Medicine is the fact that it does represent partnerships. This is a partnership not only with the Peterson Center for Healthcare, but with the Bipartisan Policy Center, with the Harvard School of Public Health, with the Commonwealth Fund, and with all of you who are leading the activities throughout the nation. And that's the spirit that we want to capture as a National Academy as we move forward throughout our activities. The National Academy of Medicine isn't the only new configuration of an older problem or older issue. The issue that we're dealing with today in finding better ways to treat and improve the health of high-need patients is also being considered in some ways in a new context, because we now have a much better sense of the nature of the complexities involved. We have a better sense of the multiple issues that have to be engaged simultaneously to engage them. We have better incentives that are embedded in the legislative support provided for our health financing system, and we have better models of care. So the first assignment for everyone in this room is to suspend your disbelief. Disbelief that these problems are so thorny and they've been around so long that they cannot be addressed, because this is a very different time. I want to wrap up my brief introductory welcome and opening remarks by giving all the credit for this meeting to a splendid planning committee chaired by Peter Long from the Blue Shield of California Foundation. And you'll find in the green folders that were handed to you or that you picked up on the way in, on the left-hand side, the agenda, along with the workshop participants behind that, and biographies. And if you take out the agenda and look on the very last page, you'll see the list of the planning committee members: Melinda Abrams, Jerry Anderson, Tim Engelhardt, Catherine Hayes, Aparna Higgins, Frederick Asasi, Ashish Jha, David Myers, and Arnie Milstein, most of whom are here today. So I'd like to lead off with a note of thanks to the members of the Planning Committee. And of course, a special note to the marvelous chair, Peter Long. Peter.
Thank you very much, Michael. It's great to be here. Good morning, everyone. It's a little earlier on the West Coast, but bear with me as we get started. So first, just to reiterate the thank yous, Michael, this doesn't happen without a lot of work, but thank you to the National Academy of Medicine Leadership Consortium for Value and Science-Driven Healthcare. I think that's the first time that's been said too, so we'll mark that. Lots of firsts today. For your partnership and convening power, and particularly to the Peterson Center for Healthcare, or Peterson Center on Healthcare, for bringing the necessary attention and momentum to this work. Sometimes in philanthropy, we talk about time, talent, and treasure. So the Peterson Center has brought the treasure. In a minute, you'll hear my colleague, Melinda Abrams, who's the talent, which that leaves me with the time, which I have ample amounts of, and I'm happy to contribute to this exercise. So between the three of us, I think we'll be able to move this issue forward and make some progress today and in the coming workshops. Also like to recognize Elizabeth Malfas and Meena Bakhtiar from the National Academy of Medicine, who are the staff who've actually helped pull all this together. And for any of you who have chaired or worked on, raise your hand if you've been on a planning committee for the National Academy or Institute of Medicine. You realize what an important role the staff plays. So I just want to recognize them and give them thanks for, they really do the hard work of putting this together. And echo Michael's thanks to the planning committee. We're new together, we're learning to work together, but it's a, as others have described, a spirited planning group with lots of good ideas. So I'm looking forward to our work over the next year together to take this issue forward. This work, as Michael said, is timely and important. We now have good data and promising models in practice to support high-need patients. What we need to think about is how do you sustain it, spread it, and scale it. So I talk in foundation world that at times we can be in danger of becoming serial prototypers, that we have discovered something and we do 6 of it, or we do 10 of it, or 12 of it, and they're promising practices. We commission an evaluation, we publish our reports, and we at a foundation or others researchers move on to our next topic. And we've washed our hands and said, we've solved this issue. On this one, that's not good enough. I mean, these are high-need, vulnerable populations. This is, in a sense, one of the core issues of, are we going to get the healthcare system right? And it is clearly not good enough to have great models in Oregon, Minnesota, Massachusetts, the M states, Massachusetts, Maryland, and that's enough. That's not nearly enough. What the goal here is to have a high-quality, low-cost system that meets the needs of our most vulnerable citizens and fellow citizens. So I think that's the challenge here. As we have data, we have models that work, and we're going to hear a lot more about those today and in the coming workshops. The challenge is really, how do you move from this place, this, as Mark Smith, my colleague at the California Healthcare Foundation would say, how do we move from the end of the beginning to what's next, right? We have a very strong beginning in terms of our models across the country and some great work that's been done over several decades now. The question is, how do we use that to move forward? I want to just share a couple of observations about my perspective on this. It's an interesting one. As I read the briefing materials in the GAO report, I was reminded, and Gary Claxton here can back me up, as a young analyst for the Kaiser Medicaid Commission, many years ago, Dr. Diane Rowland, her favorite chart was a 2-bar chart, and the punchline for those of you who've heard Diane speak is, the Medicaid program consists primarily of women and children, and yet the vast majority of spending goes towards seniors, persons with disabilities, and the dual eligible. And we had the bar chart, and for every presentation we gave, there was the large population swath who are women and children, and then the costs, which were concentrated among a few. And people can all in this room cite the statistics of 1% with 20% of the spending, or 5% and 50%. And it was probably reassuring and slightly disturbing to see the GAO report with the exact same statistics now. This was 20 years ago. We still have the same challenge in front of us. So it was both a comforting fact and reassuring, and at times a call to action that we need to do more. Then I had the privilege of running a community health center, an Indian Health Center in San Jose, California, and I had the experience of seeing firsthand how a very small percentage of our patients, a handful or 2 handfuls of our patients, were by far our most intense users of services. And we provided a comprehensive services, so they would use oral health, mental health, community health services, medical care, behavioral health services, and every bit of support that we could give them, job training and everything. And it was amazing to see how these individuals had both complex psychosocial needs, medical needs, mental health, behavioral health needs, and unless we addressed them holistically over time, we were never going to make progress. Our least effective solution was to call 5150, to call the police to help them detox so that they came back 3 days later to get our next set of services, or to say we couldn't handle it and send them to the ER so that we only saw them back 2 weeks later. They were our patients, they were our community. And so it was a real life lesson in how do you address the complexity of the human condition and kind of really understand it in all of its complexity and understand what you can work on and then what you need your partner organizations to do. And fast forwarding now to the Blue Shield of California Foundation, we're deeply involved in the intersections between domestic violence, behavioral and mental health, and physical health. And so we've been supporting our state in our state Medicaid 1115 waiver process to develop the concept of whole person care, which I think seems to anyone outside of the health sector would seem like a V8 moment of course we're going to treat the whole person. But within the health sector, it seems new and novel that we're going to do whole person care. But it really means an integrated approach, and that really thinking about all of individuals' needs, particularly those vulnerable populations, low income, on Medicaid. And so it's been an exciting kind of full circle to start with a chart, to kind of live the experience, and now to be able to work on some of the policy levers that are addressing this population and beginning to address the issue. I just want to share 2 facts, and the reason is not, we're going to have an array of ideas. I hope today, if we haven't created a little bit of murkiness and muddiness, we haven't done our job, because one of our goals for today is to understand and really think about the complexity and heterogeneity of this population. So the title is about high need patients or high need individuals. That is an incredibly heterogeneous group of folks, from dual eligibles, persons on Medicaid, persons with behavioral issues, physical disabilities, mental disabilities. There's a wide range. And I just want to share a couple of statistics from our perspective at Blue Shield around behavioral health and domestic violence in the intersection, just to give you a flavor of the complexity of the topic. Healthcare costs are twice as high in AHRQ data, so thanks, David. Healthcare costs are twice as high in diabetes and heart disease patients with depression, right? So it makes sense. You think about if you add a comorbidity, you add a secondary condition, twice as expensive. According to AHRQ, domestic violence victims have higher healthcare costs and use than other women even long after the abuse has ended. And I think you've seen in some of the materials the intersection, although it's not a front and center issue, the intersection of violence and trauma for some of the patient population, and the intersection, how that has an exponential effect on their need and use of healthcare services. And then one from our colleagues at Futures Without Violence about the intersection. Women who have experienced domestic violence are 80% more likely to have a stroke, 70% more likely to have heart disease, 60% more likely to have asthma, 70% more likely to drink heavily than women who have not experienced intimate partner violence. And my point here is not to say those are the most important. My point is to say that it's to understand if we're really going to solve this issue and solve it systematically at scale, we truly have to understand the complexity. This is not a simple pie chart. There's not a simple silver bullet or linear solution to this. I'm imploring as we take on this work that we really actually understand and embrace the complexity, and then we try to get to simplicity and solve it. I don't want us to stay in a complex and murky world. So what we want to achieve, as Michael said, this and upcoming workshops are going to seek to help us coalesce on what we've learned to date and ultimately translate those insights into application for policymaking, practice, payment, and measurement transformation. Just to put a fine point, not to put too fine a point on it, this is not a theoretical exercise over the next year. The goal is really to spur further action and to spur further action at scale. So while we will, and you saw, refer to papers in the literature, and we will have the best and brightest in the country speaking to us, the goal of this endeavor is actually to lead toward greater action on multiple domains. So this first workshop today is about prioritizing where we want to take a deeper dive. So you'll see we're going to put a lot of things in front of us. We're going to talk about a lot of different issues, populations, models, and raise some questions. The goal at the end is to understand where to take that deeper dive, where there's a confluence of factors of high need, promising models, good data, policy opportunities, where those all things come together and it's ripe for future work. Just to note, we will not, I think, at the end of today, have the taxonomy of high need populations worked out. I would say that's not the place to do it in a workshop of 100 people to get us to actually figure out who this population is. So we will have a subgroup as part of this project thinking about working with the Commonwealth Fund, thinking about the taxonomy and really getting our handle on particular subgroups of the population. The second workshop will be led by our colleagues at Harvard School of Public Health, Ashish Jha, and Jose is here today, Jose Figueroa, who you'll hear from in a second. And they're going to share some findings of deeper analytic work about spending patterns, utilization among dual eligibles, commercial patients. So they're doing deep analytic work so we can truly understand use patterns, cost patterns, what the relationships are, so that we're actually solving the right problem. So we're not solving it with 2011 data or 2008 data. We're actually looking at the most recent trends, understanding them through modeling. And that will be a highly interactive workshop either later this year or early next year. And then we'll finish the third workshop. We'll be in partnership with the Bipartisan Policy Center. Catherine and Bill are here, you'll hear from in a second, who will explore the policy environment for wider adoption. I think we all know that experiments without a policy and payment framework to supporting them will continue to be experiments, and they'll continue to be pilots. And so the third will be, what do we know in the policy environment? More importantly, what can we do in the policy environment? Let me finish with a couple of logistics. One of the things I think the Planning Committee, the first thing that we said was to ground our work, we want to hear from human beings at the beginning. Not that we're all human, but hear from people who are experiencing these issues. So one of our commitments in this process was to start each with a real life story and start with a person who's experiencing these so that we ground our conversation in reality and don't get lost in only facts and figures and insights. And so that's the way we'll start today, and we've committed to start each of our workshops, and our intention is to end with that as well, to make sure whatever work we've done is reality tested against people's expectations and aspirations. The morning panel will be a lot around segmentation and thinking about who the population is, understanding that better. And the afternoon, after lunch, we'll come back and hear about some successful models and then begin, and I emphasize begin to have the conversation of what it would take to scale, sustain, and spread those models and begin to say, why is something working in one place or in 4 places? How can we make it work in 50 or 1,000 across the country? A couple of logistical items. Most presentations are going to use slides. We will, as soon as we have permission from all the presenters, make those slides available to you. The restrooms are to the right here. And there'll be a box lunch provided that you can enjoy in this room, in 101, which is around the corner, or in the atrium lobby on the 3rd floor. One of the things we've heard from people again and again is don't over-program us. They're amazing, smart people in this room, and you all want to talk to each other, which we respect, so that we will not have a program over lunch. It'll be an opportunity for you to network with your colleagues. And so that's it. I'm looking forward. I think that we are in a journey, as I said. I think we're at the end of the beginning, and I'm hoping that the second act is going to be an incredibly productive and fruitful act that we will write together with you. And without further ado, I will welcome up our partners to hear. As Michael said, this is a partnership endeavor. And I'll invite our partnership panel from the Peterson Center on Healthcare, the Bipartisan Policy Center, and Harvard to come up and introduce themselves and talk about their elements of the project. Thank you.